Hello, welcome to Module 4, Endocrine and Metabolic Disorders. This is a very busy module, lots to talk about, so let's get started. Calcium abnormalities. So with this, it's either too high or too low. Too low, you see those finger spasms, and you have paresthesia, seizures. Remember your special signs, especially when you're looking at test questions. Causes for low calcium. You can see there's a lot of different medications, diet, kidney disease, hypoparathyroidism, high calcium. Can cause lethargy, confusion, coma, arrhythmias. That's an important one to remember. High blood pressure, kidney stones. A lot of times they can be caused from cancer, hyperparathyroidism. Treatment for that, normal saline, loop diuretics, dialysis. Obviously, if it's low calcium, you want to treat it with calcium. Osteoporosis, decrease in your bone mass, deterioration of bone tissue, increased risk of fracture. Symptoms, decreased height, vertebral fractures, back pain. More than 10 million people in the United States are affected by this. Risk factors, age, women, Caucasian, medications, medical conditions. All of those things are going to increase your risk of osteoporosis. For example, bariatric surgery, those PPI medications, lots of other things can put you at a higher risk category for osteoporosis. Chronic steroid use. Uh, Diagnosis, a DEXA scan less than minus 2.5 standard deviations. Treatment, weight-bearing exercise, calcium and vitamin D supplementation, smoking cessation, limit your alcohol, fall prevention, and also possible medications if the patients meet that criteria. Fosmax and Actonil are your first-line medications for this. Hyperprolactinemia. That's a condition of elevated serum prolactin. It's anterior pituitary gland. 40% of these pituitary tumors are prolactinomas. If you're going to draw a prolactin level, it has to be drawn fasting. You can see your symptoms here, okay? Loss of menstrual cycle, infertility, sexual dysfunction, visual problems, headaches. You want to evaluate this with an MRI, okay? That's going to be the best way to see this. Otherwise, you may not pick it up. If they're symptomatic, you can treat it. If they don't have symptoms, it's monitoring only. If they're resistant to treatment, then they may require surgery. Polycystic ovarian syndrome. This is abnormal metabolism of androgen and estrogens. Symptoms, menstrual dysfunction. They have increased hair growth, infertility, obesity, metabolic syndrome, diabetes, sleep apnea. It's a very complicated diagnosis because it's not necessarily one specific test that's going to diagnose this for you. You have to rule out other disorders. So, how do you work this up? Thyroid function tests, prolactin level, testosterone, HCG, lipid panel, FSH, LH. You always want to involve GYN, endocrine. Consider imaging, transvaginal ultrasound. Look at their ovaries. You may need to get a pelvic CT scan. Treatment, diet, exercise, weight loss. That's mainstays of treatment. Oral contraceptives, anti-androgens such as spironolactone, metformin. Those are all first lines. Cushing's syndrome, persistently elevated cortisol levels, commonly drug-induced. Okay, you can have a primary Cushing's syndrome, which is not drug-induced, but most of the time it's drug-induced. Symptoms, moon face, buffalo hump. Remember those two things. Central obesity, striae, acne, easy bruising, avascular necrosis. Workup. Midnight serum or salivary cortisol level. A lot of times this is done times 3, meaning it's done 3 nights in a row. 24-hour urine-free cortisol. Low-dose dexamethasone suppression test. Sometimes they do all 3 tests to diagnose this because one may come back positive, but the other 2 are negative. So this is another very complicated diagnosis to make and should be referred to endocrine. ACTH level. Treatment, discontinue your causative agent. If the cause is a tumor, obviously you need to remove it. Adrenal insufficiency, low levels of cortisol secretion due to inadequate stimulation of the adrenal glands by ACTH or a lack of production by the adrenal cortical hormones. So this is Addison's disease, autoimmune, and you may have an acute crisis. Symptoms: chronic fatigue, anorexia, nausea, vomiting, weight loss, recurrent abdominal pain, weakness. You may crave salt. So that would be something that you would want to remember in regards to Addison's disease. Diagnosis: rapid ACTH stimulation tests and CT scan of the adrenal glands. Treatment: steroid replacement. Usually you give the hydrocortisone. Hyperthyroidism: excessive secretion and synthesis of one or both of the thyroid hormones. Graves' disease, toxic goiter. Plummer disease, toxic multinodule goiter, toxic adenoma, or thyroid toxicosis. Screening with TSH. Your TSH is going to be low. Free T4 will be high. T3 will be high. Okay, and they may have anti-TPO antibodies, but they also may not. It depends on the condition. So your symptoms: anxiety, sweating, heat intolerance, palpitations, tachycardia, high blood pressure, lid lag, tremor, muscle weakness, weight loss, loss of menstruation. Your treatment: beta blockers, anti-thyroid medication, radioactive iodine, surgery. But first line, beta blockers, bring down their heart rate. Hypothyroidism, very common, deficiency of your thyroid hormone. Autoimmune, Hashimoto's, and then iron deficiency. So iron deficiency is the #1 cause of hypothyroidism worldwide. Symptoms: fatigue, weight gain, cold intolerance, dry skin, hair loss, depression, constipation, all of these things. Your TSH going to be high. T4 could be normal or low, and your free thyroxine index low or normal. Treatment: thyroid replacement therapy, and then you can have a discussion. Do you want to do it with the natural or synthetic? There's a lot of research into which one is better. Sometimes one works better than the other for a patient. Your dosing: 1.6 micrograms per kilogram per day for healthy individuals. Pregnant women require dosages 25% higher. People that are elderly and with ischemic heart disease need 1/4 to 1/2 of the dosage. Thyroid cancer. It's the most common endocrine cancer, 1% of all new cancer diagnoses. Papillary is about 80%, follicular 10%, medullary 5 to 10%, anaplastic 1 to 2%, others rare, okay? Medullary is the bad kind of thyroid cancer, like the really bad. And I'm saying, all cancer is bad, but medullary is very bad. Most common in patients over the age of 60 and under the age of 30. So this is a younger person's cancer, okay? And also in males. Symptoms: they usually don't have any, okay? They may, if they have a symptom, feel solitary nodule, painless, hard, and fixed. Diagnosis: you're going to do thyroid studies, calcitonin level, thyroid ultrasound, that's going to be your mainstay. And then they have a fine needle aspiration. Treatment: surgical. Parathyroid disease: secretes PTH, your parathyroid hormone, maintains your calcium levels. That's what your PTH does, maintains your calcium level. Primary hyperparathyroidism, that's 85%. Adenoma, okay. Secondary: chronic kidney disease, okay. What you see from that: osteopenia, kidney stones, weakness, fatigue, nausea, vomiting, confusion, if they have hyperparathyroidism. How do you work this up? Ultrasound or a nuclear medicine study, depending on what the cause is. Okay, if it's an adenoma, surgical. If it's from chronic kidney disease, it's going to be some type of a medication. Hypoparathyroidism. Symptoms you're going to see with this: muscle cramps, neuromuscular irritability, emotional instability, ataxia, prolonged QT. So you want to think about this, again, it's tied to your calcium levels. Work up, parathyroid level, vitamin D, calcium, magnesium, phosphorus. Treatment: administer calcium, vitamin D, and then, sometimes they need some type of a surgery, auto transplant, or gland. They can actually put that underneath your skin. Type 1 diabetes, severe insulin deficiency from beta cell destruction, which produces hyperglycemia. And hyperglycemia develops once 80 to 90% of your beta cells have been destroyed. Your symptoms: polyuria, polydipsia, polyphagia, unexplained weight loss. The onset will be sudden and usually in children, and it will usually present with DKA. Your A1C and glycemic targets will vary by patient age, so it will be different depending on the age of the child. It will require frequent self-monitoring and lifelong insulin therapy, long and short acting. You do not give oral medications with type 1 diabetes. So, your treatment: diet and exercise, lifestyle management. You want to do yearly eye exams, foot exams, check their kidney functions yearly basis, microalbumin, GFR, blood pressure, cholesterol. Type 2 diabetes, fifth leading cause of death, United States, contributes to everything else too. Reduces your life expectancy, okay? Symptoms, all the same. How do you diagnose it? Fasting glucose above 126, 2-hour glucose over 200, random glucose over 200 with symptoms. Goals of treatment, reduce your complications, okay? A1C goal, less than 7. However, some of your patients may need a higher goal, especially your elderly people. First line, we're going to have that on the next slide, but always your first line is going to be lifestyle management, okay? That's weight loss, diet, exercise, stop smoking. Management, your A1Cs, eye exams, microalbumin, foot exams, blood pressure, cholesterol. So, as you can see here, this is kind of how you go down, depending upon where the patient starts with their A1C, and which medications they need to go with. Hypoglycemia, more common in the women and elderly, low blood sugars, causes endocrine disorders, bariatric disorders, insulinomas, non-isolate cell neoplasms, liver disease, pregnancy, medications, alcohol. Make sure they're eating small, frequent meals and eating lots of protein, because protein is going to help maintain their blood sugar levels. Malnutrition, deficit in their muscle mass, it'll deplete their visceral protein, nutritional imbalance, associated with chronic illness, aging. More than 6 million older adults are at risk. Frail older adults and over 80, okay, and over the age of 85 is more prevalent in women. Risks, poor diet, medications, low education, social isolation, and poverty. You want to treat their cause, maybe consult dietary, give them protein supplements, and work with your care management. Obesity. Obviously, this is a very large problem. Body weight in excess of 20% over ideal body weight. That's 2/3 of Americans. In adults, BMI 30 plus. Children at or above the 95th percentile. There's upper body and lower body. Obesity, contributing factors, genetics, environmental and social factors, cultural, psychological, and medical conditions. Treatment, diet and exercise, medications, bariatric surgery. Goal, risk reduction of future complications. Metabolic syndrome, syndrome X, or insulin resistance. This increases your risk for CAD, diabetes, fatty liver, and cancer. Symptoms, you can see all of those here. Everything we've pretty much already talked about. They have to have 3 of those things listed below. Your glucose, blood pressure, triglycerides, your HDL, and your waist circumference. 3 of those, you're diagnosed with metabolic syndrome. Your treatment, lifestyle. Weight loss, statins, niacin, fibrates, omega-3 metformin, and getting your BP at goal. Gout is inflammatory arthritis caused by overproduction or underexcretion of uric acid. Recurrent painful attacks of monoauricular joint inflammation. Symptoms, swelling, usually to the great toe, usually one-sided, very abrupt. Treatment, NSAIDs, indomethacin, corticosteroids, colchicine, allopurinol, more of a long-term treatment. Your education, avoid those high purine foods like seafood, also alcohol, beer, soda, sugar, pretty much everything you'd want to eat. Growth disorders. So you're going to have growth hormone deficiency, okay, constitutional growth delay, growth excess. All of these you're going to see in children, okay? You want to do a workup, you can see that below, CBC, SED rate, chem, panel, urinalysis, growth factors, thyroid, bone age, genetic screening, okay? Constitutional growth delay, common variation, tends to be seen in families. Otherwise, you're too short, you're too tall. Precocious puberty. It's the initiation of puberty in girls earlier than normal. 95% of girls will have signs of puberty at age 12 and get their periods by 14. 85% of boys increase testicular volume between ages 9 and 14. So you can see that true precocious puberty is less than 8 in girls, less than 9 in boys. Usually idiopathic in girls. 30% of boys may have CNS tumors. So you can see delayed puberty here. The workup, most important, refer to pediatric endocrine for management here. Inborn errors of metabolism, usually single enzyme or cofactor. Super important to refer to your genetic specialist Children's Hospital, whose treatment is dependent on the disorder. They do neonatal screening, currently 52 disorders. PKU, this is it's treated with a dietary intake modified formula. This is something that is screened for at birth. All right, so hopefully we got through all the endocrine disorders.